whether it's endovascular or whether it's surgical, what are some of the most advanced tools and techniques being researched and studied in the treatment of PAD?
Yeah, there are all kinds of now new exciting trials specifically for below the knee locations. We're talking about bioreabsorbable scaffolds. We're talking about drug-eluting stents. We're talking about other stents that are just not drug-eluting, but just stents that are more like a small Sapera stent. We're also looking at drug-coated balloons, sirolimus, as well as paclitaxel, and so I think it's an exciting new world, as well as some of the other modalities that we're using, such as shockwave therapies and some of the more exciting balloons, specialty balloons that are just around the corner.
Dr. Runback, what are some of the research opportunities and studies that you're participating in that you're really excited about?
Yeah, well, there's a lot going on. It's a very exciting time. So, Dr. Beasley, hey, Bob.
Hey, John.
Hey, and you'll find, by the way, we all know each other quite well. This is a very, unique community in that regard. So, Dr. Beasley talked about a lot of them. Some of the things that he sort of might have overlooked is there is now some work being done with temporary scaffolds. That is, rather than putting a stent that's permanent and may or may not cause inflammation and scar tissue buildup, it's just there temporarily allow better initial healing of the blood vessels below the knee, particularly as you deliver drug. We're actually working on a device that helps prevent debris from breaking loose and go downstream during procedures, which is one of the risks of many procedures, including atherectomy. So we improve the safety and long-term benefit. Dr. Joy, if we can get him on, has developed a device that's an alternative for patients who have blockages in the arteries between the hip and the knee, which is a non-surgical bypass, which is certainly very, very exciting. So there are others as well. These are some potentially very exciting technologies, along with what Dr. Beasley talked about. And part of the question earlier was, how do you find a doctor? And one of the good ways to find a doctor is ask your doctor if they participate in clinical trials, because that will certainly give you some insight into cutting edge physicians.
I'm curious. I wanted to go back to talking about the one from Dr. Joy, because I think that this is really interesting. It used to be called PQ bypass, but then now it's called, I believe, Ptab. And I'm wondering, can you describe a little bit further as to what this technology is, how it works? It's a minimally invasive bypass utilizing the vein and some stenting, right?
Yeah.
So, an interesting finding, and this is at many levels on the leg, is that while the arteries may be very diseased due to hardening of the arteries, the veins, which typically return blood to the heart, are often well preserved and not that diseased. They certainly can go hand in hand. But in those cases where the vein is preserved, it lies right next to the artery and provides, in essence, an opportunity, to use the vein to deliver blood flow instead of the artery, kind of get it to kind of either be a pathway through which you can place stents to deliver blood flow downstream across blockages, or in the case of DVA, to get it to reverse flow. So, the bypass that Dr. Joy developed basically is such a technology where it goes from the artery above the blockage into the vein, somewhere around the level of the hip, across the vein with a stent, which provides, in essence, a tube within a tube, the outer tube being the vein and the stent being the inner tube or graft, and then re-enters into the blockage below, re-enters into the artery below the blockage. So it goes from artery through vein and back into artery to create a non-surgical bypass. Very exciting stuff.
I want to talk about also, you guys mentioned the biodegradable scaffolding. I had interviewed the CEO of a company that was working on something like that from a couple of years ago, but I heard they had gone to Australia to go and work on doing some research there and some clinical studies. What are you studying here in the States on that?
So I'll chime in on this one. There were two exciting studies. One has been complete. It's the Life BTK study, Abbott sponsored, and they were looking at the Esprit stent. It was a sirolimus eluting bioreabsorbable stent that is placed below the knee, and pretty much all the way down to just above the ankle. And this stent or scaffold, as it is, will be reabsorbed within about a year and a half, and leaving nothing behind. But you'll be having the benefit of having a stent, which holds the, when you're talking about tibial vessels, you're talking about a lot of recoil, and you're talking about some dissections down there. And up to this point, we haven't had any ability to treat that. The other device is one that they're just trying out. It's the Motus stent, and it's a little bit better visualized than the Abbott stent. And again, they have just started the trial for this particular stent.
And Dr. Renbeck, are you familiar with these biodegradable stents?
Yeah, we were a part of the Life BTK trial. We don't know that data yet, but in the hearts, the Esprit trial actually performed very well. It's a great idea that you kind of get temporary scaffolding or vessel support without the long-term risks of inflammation associated with these. We're on the Riva, trial. 4S is another device. I think we're going to see more of these as well. So yeah, definitely familiar with them. And then the alternative, like I said, of the temporary scaffolds, the spur technologies and other technology, free flow,
That's right.
Which are just really inflated for a few minutes, but do potentially allow better healing and importantly, better drug delivery into the wall to help prevent scar tissue buildup.
I think that's an exciting new technology, the spur technology, where you can really, I think you can, you can inflate the balloon, and then you can have multiple little spurs or little pricks going into the blood vessel wall, and as for delivery of a drug to help prevent restenosis, and also I think to help prevent recoil. So it's a really exciting new technology. And I'll also add that they're almost finished. The Micromedical Solutions has a small microstent, which is about 7 or 8 patients away from being completed as far as enrollment. So that's another technology which is out there. So again, I think there's just a plethora of devices and techniques that are now coming to the front. And if you compare to what we had 10 years ago, 12 years ago, all we had was basically coronary balloons going down there, and you're inflating these little things that are about 3 centimeters or 4 centimeters long at the longest, and you're inflating them going up and down the leg. I know John can remember that. Those were some difficult times, but the way we've progressed has been amazing in just such a short period of time.
And someone was just asking about the tibials and what are the treatment options for the tibials right now, and how soon are we going to see some of these newer technologies to help maintain those vessels open once they are treated? Because those ones tend to reocclude a lot quicker, don't they, than some of the above the knee vessels? And can you explain why that is?
You want me to start with this, Bob, or do you want?
Yeah, John, you go ahead and take that, and then I'll finish up.
Sure. So the tibial vessels are smaller vessels. They tend to have longer blockages, and they have a high amount of calcification. So they're more complex for many reasons. The truth is, by having the ability to do such things as pedal access, most of the time, 80 to 90% of the time, these blockages can be crossed to restore blood flow. And of course, the goal is not just blood flow, but to restore targeted blood flow in the region of the foot where there might be wounds, which we increasingly are able to do. What I tell our patients up front is that based upon clinical trials, mostly in Asia, there's up to 40% risk of needing to repeat the procedure to keep the artery open long enough for the wound to heal. After wounds heal, you need less blood flow to maintain the skin than you do to heal a wound. That's an appropriate expectation. Our center is about 25% because we've evolved some of the techniques. I'm sure Dr. Beasley and Dr. Joy do what we call optimized angioplasty, utilizing intravascular ultrasound for sizing, slow inflations, fixing dissection, stenting appropriately. But they don't stay open as reliably, but still wound healing and amputation prevention needs 80%, in dedicated centers. You just have to be diligent and be prepared to repeat procedures as an outpatient, maintaining patient quality.
Yep.
Well, and I can tell you, I echo everything that John said. It's just a different animal. The tibial vessels are different than any other vessel in the body, and you have to really have these expectations with your patients that when you come to see me, if you've got these wounds, you're probably going to be a patient with me for life. And that doesn't mean that you're going to have these wounds coming back, but we have to keep a really close eye on our patients and have good serial follow-up, because these wounds can just kind of like just fester up and just pop up in a week or two. You can go from having like a little bump on the tip of your toe to having a black toe going into other toes within a week. So you just have to stay on top of it. And in fact, I give my cell phone out to every single patient that I have. I mean, they're very respectful. But I tell them, look, if you have a problem, if you get a wound, or if you get a toe problem or any type of breakdown of tissue, call me right away and let's get you in and let's see what's going on. These things, they do go down. And that's why I'm so excited about these new devices. Now, these new devices are going to keep it open longer, but I think they're still going to go down. And I'd just like to mention one thing and sort of stress one thing that John said. Once you get the wound healed, I mean, if the patient comes back to see me and the artery I opened to feed that wound goes down, but they're fine, they're not having any pain, the wound's gone, I don't go back in there and try to play around with it at that time, but that this is where the patient's at a steady state.
I think that's really important. And so how soon can we see some of these technologies, and how do patients have the conversation with their doctor about these options that might be available, or whether the doctor should be exploring those options and get involved in those studies?
So they're coming out, I think fairly soon. I'd say by the end of this year, there'll be some devices that will be available. The ones that we were talking about, more of these devices will be 2024, 2025, because you're going to, some of these devices, you got to get some follow-up. Since they do have drug on them, you're going to have to probably get a year follow-up to see and make sure that the safety endpoint is met, which it appears to be. A couple of these drug-coated balloon trials that had this one device that had this one substance called paclitaxel on it kind of failed because it's such a very difficult landscape down there. But I'm very optimistic about some of the newer ones, especially some of the sirolimus, which is another type of drug. And I'm optimistic about some of these scaffolds and the spur technology that John was talking about. So, it's just around the corner. And, any one of us that's here talking, John, myself, Dr. Mustafa, Dr. Dua, some of the rest of the guys, we're pretty much all involved in most of these trials. So if you were a patient of one of ours or somebody like us that are involved in these trials, then you have an opportunity to perhaps get some of this technology now before it's FDA approved.
Dr. Joy, are you there?
Thank God I'm a better interventionalist than I am a IT guy.
Thank God.
So sorry for that.
That's okay.
I won't bore you with what I've been doing here to try to get on, but I'm happy to join you, and I appreciate you guys talking over me while I fumble around.
No, it's fantastic. And Dr. Runbeck did a great job explaining what we talked about was the minimally invasive bypass that you're helping to develop and bring to market. And, we might expect that to market sometime in the spring.
April. What's been newly dubbed as the Ptab procedure, percutaneous transarterial bypass. We hope to have FDA approval in April, and that's going to be, something that, certainly the physicians that are in and engaged in this battle will want to be a part of, because these are, one of the challenges above the knee that we've had over the years is maintaining patency in these long segment lesions. We can open them and there's immediate gratification and there's immediate benefit, but the durability has led to just a kind of a cascade of multiple different devices we use to try to keep these things open. But on the tibial front, I know that John's been very engaged with micro CT and laser below the knee. Dr. Beasley with the micro stent. I'm really excited to see that data come out. Having a scaffold below the knee is, I think, an important advance. And Jihad, I don't know if he's on, but certainly with limb flow, the word is early still on that, but we're up against it with a lot of these patients. So I think,
well, it's interesting when it comes to when it comes to lymph flow, we haven't really talked about the deep vein arterialization in this session. If you want to go into what it is and what are the indications for it, that would be very helpful.
Instead of trying to get through the artery, many times we encounter patients that they're referred to as having a desert foot. They've got no arteries going anywhere, just fine little collateral channels, and certainly not enough to sustain the foot or to allow it to recover from gangrene or an ulcer. And in those cases, there's really just not a way to get through. The people that are on this panel, we spend every day getting through blockages that most people don't even think about attempting, but there are just situations where there's no opportunity to restore direct arterial flow to the foot. So the idea stems from an old surgical approach where basically trying to tie the arterial flow into the venous system. So in a method basically where, in contrast to maybe what we do with the arterial bypass, we're connecting the artery as distal as possible to the deep venous system of the foot and arterializing the flow through the vein. So basically pumping arterial blood into the venous space in hopes of getting the oxygen and the nutrition down to the foot that's necessary to heal.
Mm-hmm. Fantastic. And Dr. Rumpach, do you have anything to add? I'm curious about the viability and the long-term durability of the DVA and what research has supported that. I know they were going into, I think, the PROMISE 3 study on that.
Yeah. European data as well. So, so we've done close to 100 DVAs now. And it's been interesting. We've learned quite a bit and we continue to learn. Our data is that, the grafts we place connecting the artery to the vein below the knee to try to get venous blood flow, backwards flow through the vein into the foot, don't stay open. In our experience, almost 40% of the time, you have to do repeat procedures to try to keep them open. And at 6 months, only a small percentage stay open. However, it's doing something magical in the sense that in our experience and in the PROMISE data, more than 70% of patients actually heal their wounds. And it may be that, we're restoring blood flow and perfusion or oxygen delivery for sufficient time for the wounds to heal. As we said earlier, once you heal the wound, you get by with less blood flow. We've actually found a number of instances now where in our second look, you see arteries you didn't initially see. Maybe just increasing the overall blood flow now allows connections between arteries and veins to be visualized, and previously hibernating arteries to become apparent, which can now be fixed. Mm-hmm. We still have a lot to learn. Where we create the DVAs, how large they need to be, how often we need to monitor them, what the best surveillance is to need for intervention. But certainly the limb salvage data, prevention of amputation, is very encouraging, and this is definitely going to have a role in patients who otherwise have no option.
So I'll add to that. We have 5 centers down in Florida, from Stewart down to Coral Gables. Not all 5 of our physicians perform these, but we will, we'll amongst ourselves. We certainly love this procedure. I mean, this is taken patients that, for sure, that had this desert foot that Dr. Joy is talking about, taking these patients that for sure would have gone to amputation. And given, like John said, 50 to 70% of those patients now are walking. They still have their foot on. It's been a very it's a significant advance for treatment of this disease.
And I think that it's important to note that there is a particular company that is designed an in the box deep vein arterialization package or DVA package. They're only going to be providing that, at least in the meantime, for hospitals, but it's the ASCs or ambulatory surgical centers and office-based labs are able to still perform the procedure using the devices, what we consider off the shelf. Is that correct?
That is correct.
And so the option should be available no matter which facility you decide to go to, whether it's a hospital or an office-based lab or ASC. but not every doctor does it. Do you all see the number of doctors who are learning it increase at a rapid rate, or is this still slow to go?
I think it's still pretty selective. It's a very, very advanced technique, and it requires really, really unique catheter or endovascular skills that not everyone's entirely comfortable with. We're seeing way too many amputations, without this being offered, and I think there's room for improvement. And part of that is with the off-the-shelf devices. Obviously it's streamlined. It's sort of putting together, cobbling together pieces intended for other purposes. That being said, I personally have done 3 live DVAs at national and international courses. So there's an interest in it. People want to see how it's done. I want to be able to learn how to do it. We run courses locally. I think Bob does as well, probably Jim as well. And, always one of the questions is during the course, can we do a DVA? So, this will continue to grow. There's some uncertainty until that data sort of comes out, until we understand a little bit better. But yes, there's interest, but the utilization now, I'd say, is probably minimal amongst the vascular surgery community.
And, we get this question a lot, and we have it, people are writing in right now in a variety of different forms, but it's really about melting the plaque. And we know when it comes to general blood clots, doctors have an option for using clot busting medication, either through a drip or catheter directed delivery. But what about something that could melt the toughest plaque, meaning, the calcium? I read about a 2017 study in Aberdeen of a new drug, or a newer drug at that time, troduscamine, that supposedly could reverse the effects of atherosclerosis, but I haven't seen anything since. Have you seen any new technologies, any new medications that could necessarily melt the calcium or the tougher plaque in our arteries?
That's a the liquid Drano that we're all looking for is unfortunately not on the market or on the horizon. There have been some interesting early data with a newer version or newer versions of statins that they bolster HDL, the healthy cholesterol, which is always unfortunately low in patients that have these vascular conditions. I would say in comparison to using thrombolytics, drugs that dissolve blood clots in arteries and veins, which is quick fix and generally very reliable, getting rid of plaque, resolving is not the right answer, but getting a regression still requires the most difficult of work, especially for us humans. We've got to eat right. We've got to exercise. We've got to take our meds, control our blood pressure, blood sugar, blood cholesterol, not smoke, all those little things. And, I'm sure all of us do this, and harping on our patients every day. It's really a matter of getting straight A's in every one of those departments in order to have success. But unless I'm missing something that would have been Nobel worthy, there's not a magic pill. There's not a magic drug that I'm aware of on the horizon that will accomplish what we're all hoping for.
Dr. Beasley, Dr. Reinbach, do you have any secrets that you're working on behind the scenes? No, just kidding.
But there are new classes of cholesterol-lowering medications, injectable medications, of different types, either given, monthly or given at first at 3 months and every 6 months, which, are showing some early efficacy, at least in stabilizing. I'm not necessarily sure. And the medication you mentioned, I actually looked it up when you mentioned it because I was not familiar with it. And apart from that sort of initial study, it's not really moved forward. So it's hard to recommend. There are some over-the-counter medications that are not regressing plaque. Most of the time you want to go with prescription medications given to you by a physician who's a vascular expert.
I agree.
Tim, maybe just on that whole topic though, and for patient self-advocacy, our most difficult vascular patients, people that have head-to-toe disease, battling with CLI, in and out of the lab, just trying to save legs. The greatest impact that I've seen in those individuals in terms of kind of quelling the fire that is behind all this has been the injectable drugs for statins, where we can drive LDL numbers down into the 20s and 30s. And that really is, I think, the current hope for people that have this affliction to kind of stabilize things and find some smooth sailing. So as a patient, if you're on this call, you're either a patient or you're looking out for somebody that you love. They should be on a statin. If they can't be on a statin, or even if they are, the question that you want to ask your doc is about these injectable forms of drugs. Every 2 weeks, every month, they just have such a huge impact.
Jim, have you seen or heard of any differences so far between Leqvio and Repatha in terms of impact on peripheral artery disease or critical ischemia? I'm just not familiar with that particular cohort.
Yeah. No, nothing published that I could point to.
Yeah. Well, we're going to be wrapping up here. I just want to, if each of the doctors wants to share a few takeaways, a few of the things that we've covered in terms of newer technologies. We've talked about the minimally invasive bypass, where you're pretty much hijacking part of the vein to reroute blood flow around a blockage. I believe that's more of a FEMPOP, femoral popliteal, instead of the femoral popliteal invasive bypass, surgical bypass. This could be a minimally invasive option that we might see FDA cleared sometime in April. We also have biodegradable stents that we talked about that are going to be hopefully coming to fruition, being studied at several locations, probably around the world. Below the knee drug-coated balloons, below the knee stents. One thing we didn't touch on, though, as we close up here, are the tacks, Phillips tacks, that are also newer and available today. Especially, if the doctor has a situation where, they overinflate the balloon and it dissects the vessel a little bit, they can just put a little mini. Is that what you would consider micro stenting as well?
It's like John, you're on the trial, but I think it's a mini little stent that you can put in if you have a small dissection, and a dissection is like an unraveling of the vessel wall, and that will cause the vessel to either have a significant chance of restenosis or reocclusion. So you need to take care of that, and you can see that either visually or under intravascular ultrasound. So these things are available. If it's heavily calcified, they do have some limitations because the radial strength is not there. I think the microstent might help that, especially in more proximal lesions. It's done some early good results. So I'm cautiously optimistic. I'm very excited actually for the next couple of years in this space, this tibial space. I think this is going to be the next frontier of medicine, and the next area that once we at least get start to being able to get longer term results, we're going to really help some folks keep their legs.
I think that's such an important point, because there's still so many doctors that are telling our patients that it's not safe or effective to treat below the knee. So just walk. And when you can't walk anymore and you don't have a landing zone for bypass, we'll just chop off your leg.
I repeat my message of don't get amputated. Obviously there are circumstances where major amputation is necessary, but if you see the appropriate doctor, it should be a last resort only. And even then, we now have some technologies. You can find a good doctor, you're an unbelievable resource. But, the idea of people who are involved in clinical trials is, really a good one, because that'll tell you doctors who are working to find newer solutions, moving forward. I'm going to leave it to Dr. Joy to wrap up. I mean, he's one of the most preeminent experts I've admired for many, many years. But I think that the future is bright, but we're not there yet.
Great.
And
Thank
Dr.
you, John.
Joy?
I mean, there's so many levels that we have room for improvement. I wholeheartedly echo, the notion I heard earlier, which is if your doctor says there's nothing I can do for you, they're probably right. That doesn't mean something can't be done for you. It just means that within their bandwidth and their skill set, it's not a capability. And so that's one of the areas that, those of us that are involved in training and education, we need to train up an army of docs that can do this. It's a huge problem, and there's not enough of us. So training and education is a part of this. Obviously, the advances that we've been talking about. If you're a patient, you're kind of rolling into a sweet spot in terms of this medicine because there's a lot of hope. So kudos again to Kim for putting this together and being a resource and an advocate for these patients. What you've done is save thousands of legs yourself, and we appreciate you.
Well, I appreciate all of you, Dr. Joy, Dr. Beasley, Dr. Runback. Thank you so much for joining us, volunteering your time, offering great insight, and thank you for being a part of what's new and what's next, and creating what's new and next, and helping to expedite it to market. So we really do appreciate you.
I pale in comparison to my colleagues, but thank you for everything you do. You're our hero.
Thank you.
Thanks, gentlemen.